we came to our launch speaker, first seminar speaker of the year. Actually wanted to introduce the two new coordinators for HIV Grand Rounds. Every 2 years, we switch off on coordinators, and we're really, really pleased. Well, number one, thank you so much to Matt Spinelli and Sarah Purrier for doing such a great job. But really please introduce Liz Imbert and Aisha Appa, both their associate and assistant professor respectively in the division of HIV, infectious disease, and global medicine. And they are going to come up and actually explain the HIV Grand Round series. And the other thing I wanted to say is really hearty welcome to the ID fellow candidates to UCSF who are online with us. We were just talking to them about the introduction of the day, and now they've come to join HIV Grand Rounds on this very special launch seminar. So please, Liz and Aisha.
Good morning, everybody. We're thrilled to be back. Sorry for that horrific noise. I can do this. Don't mind me. Nails on a chalkboard. We are just really excited to be here and be coordinating this for the next couple of years. We are thrilled to have Dr. Havlir today, and Monica will introduce her. We will just wanted to share with you a couple objectives that we have for the series that are here, that'll be posted on our website. I think as well established by Drs. Gandhi, Havlir, Spinelli, and Purrier, we want this to be engaging. We want you all to ask questions. We want this to be incredibly practical. And so all of this, I think our series is going to be designed to just keep this going and do this even more this year.
Wonderful. And we just wanted to share the schedule. So Dr. Havlir is talking today, but you can see we have talks coming up about gender affirming care, low barrier care, rapid starts and restarts, talks on tobacco and managing alcohol use, as well as cases on endemic mycoses. And then further later in the year, we'll hear more about hepatitis, as well as ID report back and weight management in our population. So we're very excited to have you all here, and we'll welcome back Dr. Gandhi.
So Dr. Diane Havlir is the chief of the Division of HIV, Infectious Disease, and Global Medicine. Really needs no introduction, but some of her really dignitary titles are that she is the Associate Chair of Research for the Department of Medicine. She is the Director of the AIDS Research Institute here. She leads an extremely large and massive research program in East Africa that has really defined paradigms of treatment, care, prevention, and how to manage non-communicable diseases called the SEARCH program. She is on the WHO ART treatment guidelines and really has had a long-standing and very distinguished career in HIV with a real focus on both the global and the domestic HIV epidemic, the latter of which she is the co-chair of the Getting to Zero initiative here in San Francisco, which is really a multidisciplinary program of everyone coming together to fight and bring down HIV to zero. So she is going to talk today about state of HIV. Where are we and where are we going? Thank you.
Thanks, Monica, and good morning to everyone in the room, and a special welcome to our ID fellowship candidates who are visiting our institution. Okay, let me see if I can get this a little bit more comfortable. Okay, so the learning objectives this morning are I'm going to give an epidemiologic overview of the state of HIV globally, in the United States, and in San Francisco. On this slide, I have a photo of Winnie Byanyima. She is the current director of UNAIDS. And shout out to Winnie, who comes from Uganda, who is really fighting for human rights, in particular in her own country, where we've seen some recent egregious human rights violations. Secondly, I will be doing a rapid fire, 5 new opportunities for clinicians to improve care in the coming year. My disclosures are I receive non-financial support from ViiV, Abbott, and Gilead for ongoing research studies. This has happened in the last 5 years, and my research is sponsored by the National Institutes of Health. So this is the cover of every year UNAIDS puts out a State of HIV report, the global report. And this year, the title was The Path That Ends AIDS. Now, for those of you who remember, this is essentially a 180 from last year when it was very negative, alarming, danger, we're not on track. Well, to be perfectly honest, things have not dramatically changed. This is really a different strategy by UN. I kind of like the strategy because they are both highlighting some really good things that have happened and the it can be done points, as well as the challenges and the reality of what we are facing. So their key talking points on this report are that many countries are reaping the benefits of evidence-based response. Treatment and prevention are saving millions of lives. Inequalities and barriers are holding back progress. People first programs have the most impact, and that greater equity will unlock new opportunities. So let's take a look at the numbers. So this is from 2022. It's estimated that are 39 million people living with HIV. This is a little bit up from last year, and of course reflects the success of antiretroviral therapy. Estimated that there were 1.3 million new HIV infections and 630,000 deaths due to AIDS. This means one person is dying every minute from AIDS, which is, as we all know, a preventable disease. So this is a graph that shows the highlights the lives that were saved with antiretroviral therapy. So just metrics, we've got nearly 30 million people who are accessing ART. And I have to step back because I was in the room when ART at the WHO came out, and it was being talked about of expanding ART beyond developed countries for a drug that costs $30,000 a year. And I cannot tell you how many naysayers were there. And this is really the AIDS community, everybody in this room, people around the world that made this happen. And this is just really one of the greatest accomplishments in modern medicine. We know that we're not letting up. We need to offer ART treatment to everyone living with HIV, and there were 1.5 million new ART starts in the last 3 years, and most people are on integrase inhibitors. Integrase inhibitors have really been a complete game changer in the pandemic. So what the graph shows is that the y-axis is the deaths that are due to AIDS, and the blue line is what actually happened. And the orange line is what would have happened if we hadn't rolled out ART. And that's how we get that there were nearly 21 million lives saved with ART. This is one of my favorite graphs in the report, the UNAIDS report this year. And TB now has the dubious distinction that it is the infectious disease that's the leading cause of death worldwide. We know that people living with HIV have increased susceptibility to tuberculosis, but we also know that ART reduces risk of acquiring tuberculosis and, of course, all other opportunistic infections. So what this graph shows is that if we look at TB in persons, you can see here without HIV, it's kind of steady. But if we look in TB in persons living with HIV, it's going down. And the reason that it is going down is because of the rollout of ART. It is also going down because TB preventative therapy gives us increased protection against tuberculosis even in people who are already taking ART. And although this has been extremely slow in uptake, and many people in this room at UCSF and around the world are working on this, it's estimated that at least 7 million people have had at least had exposure or access to TB preventative therapy. So let's take a look at the cascade in the UNAIDS Global Report this year. And this is also very gratifying to me as a person who was part of the group that proposed 90-90-90, which you are all familiar with. And this was, it was really a slogan, but this was a slogan. If you go to the most remote parts of the world, people know what 90-90-90 is. And when it was put out there, we were so far from 90-90-90, but that's what the AIDS community does. They set what people consider unrealistic targets, usually never make it on time, but they eventually get to it. And with the UNAIDS in the last couple of years ago, retooled, made it, increased it from 90-90-90 to 95-95-95, and made the point, it's not just overall, but within subgroups of individuals. And this graph shows the in 2015 and 2022 showing the improvement in these metrics. So the first metric is number of persons, the percentage of persons who know their HIV status, which is now 86%. The second one is of those people who know their status, the percentage of people who are on antiretroviral therapy. And then the third metric is of those individuals on antiretroviral therapy, how many individuals are suppressed? Look at that number, 93%. That's really incredible. And that also, I think, reflects the power of integrase inhibitors. We've advanced from efavirenz really as the global drug that we're seeing these high viral suppression rates. And very excitingly, there's some countries that have won the blue ribbon, just they have reached these 95-95 targets. They're listed here: Botswana, Eswatini, Rwanda, Tanzania, and Zimbabwe have already achieved these targets. And once again, the point is this can be done. And it's very good for countries to see other countries where this has been achieved, including our own country, where it has not been achieved yet. So I explained to you the denominators of the graphics. This is using a different denominator, and the denominator for this is the percentage, the number of all individuals living with HIV. So I'm going to refer you to viral suppression in the far right. So this is among everybody, whether you've been diagnosed or whether you're on treatment or not. The viral suppression globally is estimated to be somewhere around 71%. And you can see that's the dramatic increase from 2015 from 40%. So let's start with the first audience response. Wake up if I've already put you to sleep. So let's see if this can work. We talked about all individuals and the percentage of those that are being treated with ART. What is the percent of children living with HIV who are being treated with ART? Feel like I should sing a little song here. Do, 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 do. Okay, so let me just see, Joe, can go to the next slide? Aha, okay. So, wow, we have quite a big split. I really wish that the people in E were correct, but they're not. Okay, so this is the answer. Unfortunately, it is 55%. So about 55%. And the actual UNAIDS estimate was 57%, and that is compared to 76% among adults. How are most vulnerable beings on the planet, the children, how could we let this happen? Just really, really distressing. There's about 660,000 children living with HIV who were not receiving antiretroviral therapy in 2022. And this next bullet point is even more distressing. Children accounted for 13% of AIDS-related deaths, even though they comprise only 4% of people living with HIV. Now, fortunately, we have some very dedicated advocacy groups and lay individuals, academics, foundations that are really working hard to change this. And I hope that next year, when I present this, that these numbers look better. So let's change from treatment to new HIV infections. So good news, yes, the infections are continuing to decrease. The target for 2025 is 370,000 new infections. Really, maybe the target should be 0, but it's 370,000. So you can see that if you extrapolate this line, we are not on target to reach that. So one of the questions is, where are the individuals who are acquiring HIV? Where are they living around the world? So what this map here shows that in every region of the world. And what you can see is that the largest absolute number of individuals are in Eastern and Southern Africa. This is followed by Asia and the Pacific. And then you can see the numbers for the other regions around the world, including North America. So what about, well, okay, let's just take a look of the characteristics of people who are newly infected. 3,600 new HIV infections every single day. Remember, these are all preventable, okay? So of these, it's estimated 3,200 are among adults, age 15 and older, 46% are women, 30% are young people, and about 360 among children under 15 years of age. So I like this graph also in the UN AIDS report because it did show some of the successes and some of the major challenge areas. So new infections decreased the most in sub-Saharan Africa by about 57%. And what you can see is they also decreased in Western Africa. And we saw smaller decreases in other regions of the world, including in Asia, the Caribbean, and North America. Latin American was pretty flat just in terms of reductions. But you can see here that there are regions of the world, Eastern Europe and Central Asia, where infections increased. And even though the absolute numbers are lower, this is extremely concerning. So both in Eastern Europe, Central Asia, and we know many of these areas can be war zones in the Middle East and Northern Africa. Sex workers, their clients, men who have sex with men, transgender people, people who use drugs are still disproportionately comprise groups that are getting newly infected. However, fortunately, there were reductions in all of these groups, although they were variable depending on the region. So this is a graph from the UN AIDS report that attempts to quantify how we are doing just in terms of PrEP access. So we know we have too many new infections. We know that these are preventable. They're preventable by us getting 100% viral suppression, or at least below 1,000, because that's what we know is a threshold for forward transmission. But we also know that we need to get PrEP. And the UN AIDS has a formulaic way to estimate what the needs are in terms of PrEP in different regions around the world. And that is what this particular graphic aims to demonstrate. So the first thing about this graph is, if you look at it, there are some regions of the world. So the height of the blue bar is the number of individuals on PrEP. In some regions, there's like no blue bar. very bad. That means that these are the regions where they're not rolling out PrEP. Then secondly, that we see that the distance between the red dot and the blue bar, with the exception of Western Africa, which is a little bit perplexing, I must say, but good, of course, if that indeed is true, is very large. And it's particularly large in the Asian and Western Pacific region. And it's really terrific to see the PrEP use in Eastern Africa, but there's still a distance to the bar. And the way this is done, it's if you qualify to be within the blue bar is counted as a number, it means you've taken one dose of PrEP. Now, one dose of PrEP is not going to provide coverage or prevention. So this is a very, in my opinion, very optimistic view, really what's happening, because we know access to PrEP, we know persistence to PrEP. Many of you are working on this, is a very, very important global challenge. So we talked about the sad state of affairs with children on treatment, and the reductions in transmission to children, I would say, is equally distressing. So we really just should completely have no children that are infected with HIV. We've achieved it in San Francisco. It can be achieved. So what do we need to do to achieve that? We need to ensure that all people living with HIV have access to our therapy, but in this case, pregnant and breastfeeding women. And the top graph shows the percentage of pregnant and breastfeeding women on ART over time. And as you can see, we had a really nice, robust increase, but now it's completely stalled. We are stalled at 80%, and we have not been able to push that number up higher. Okay, so we have hundreds of thousands of women who are not receiving ART. And this is why we have children who are newly infected. We have other people, women who are pregnant, who get infected while they're pregnant or breastfeeding. And of course, this is a time that they can transmit with the high viral loads to their infants. So this was a very, I thought, interesting analysis that was in the report this year. And what the UN AIDS report wanted to make the point that, and this is, as we think about our strategies of how to solve this problem, it's like, what are the main reasons why we're having this transmission to children? And it differs by region. So for example, in Eastern and Southern Africa, there's like a third of the cases are due to women who get infected when they're pregnant or breastfeeding. About a third of the cases are women who don't get access to antiretroviral therapy. And about a third of the cases who are women who are on antiretroviral therapy, but pregnancy and breastfeeding are complicated, they stop when this is happening. So that just is very informative for us to figure out how to put in measures in order to provide more therapy and reduce infant transmission. On the other hand, in Western and Southern Africa, it's nearly all due to women not getting access to antiretroviral therapy. So I think this is very informative, and this is the way we can help to start to tailor our solutions. So now I'm going to talk about what we have here and what's on the horizon and give you some examples. I chose 3 points. First, I'm going to talk about choice models for prevention. Then I'm going to talk about long-acting agents for prevention. And I would have to say that we've got long-acting treatments for HIV, but a very exciting situation in infectious disease, and really all of medicine, is long-acting agents for multiple diseases. And during the course of Grand Rounds, for example, in the TB talk, hopefully this year, that we will talk about this and share what the latest information on this is. And then expansion and extension of person-centered multi-disease models of healthcare into the community. We are never going to solve pandemics unless we are seamlessly working with our community partners in the community. And I'm preaching to the converted, I know, in this audience, but just really wanted to make that point. Okay, so biomedical prevention. People, of course, want choices. So the questions then are, what do you offer? How do you do it? What do you gain? And there's a very, very large and robust literature about the HIV prevention choices out there using very sophisticated analysis. Well, if you had access to these, what would you do? What would you take? And they're all theoretical. Well, what I want to share with you now is what people actually do. And this is from my work, from our search group that's been conducting studies with our partners in Kenya and Uganda for the last 2 years. The overarching goal of our search that Dr. Gandhi mentioned in the introduction consortium is to test bold population level interventions to stop HIV in its track and also at the same time improve overall community health. So right now I'm going to share with you, in our search, we called Search 2.0, we conducted a series of pilot studies. I want to share with you the result of the CHOICE pilot study we did. So what we did was that we did 3 randomized trials to evaluate the impact of dynamic choice biomedical prevention compared to standard of care. And what we measured was coverage. In other words, were you taking the biomedical prevention that you chose? And I'll tell you a little bit about the intervention. We included adolescents and adults over 15 years of age, HIV negative at risk for HIV. And so the coverage was percent of follow-up time for which a participant reported use of PrEP or PEP. That's what we have available right now. And this is a description of dynamic choice prevention. So in terms of product choice, what people could take, and really important, what we said to people is, if you're at risk, we're really encouraging you and offering you to take something. You can switch back and forth. Something might be right for you now. It might change what's right for you. And we offered both PrEP and PEP. And for PEP, we did pill in pocket. We wanted to make it as easy as possible. Now, PEP is completely underutilized, I would argue, all around the world. It can be an entry point for PrEP. People can take it, and they're like, I'm not going to take a pill. But okay, well, I had an exposure. Like, I'm scared now. I think I'm at risk. I will take PEP. And the medicines we take are just essentially just like ART, okay? You take it for a month. Probably we don't even need to have it for a month, but we give it to people for a month. And if you've got it in your pocket, it is so much easier to do. So we offered people one of those 2 choices. We said, we can help you access the therapy, clinic, home. We did telemedicine. We did the study during COVID, emergency phase. We allowed choice in what testing people did. And then at this time, the standard of care was to have refills every month. That's crazy. Can you imagine having to go into the clinic every month to get your refill for the PrEP? We offered 3-month refills. And then since the beginning, Search has really pioneered patient-centered care, which I would argue Ward 86 started at the very beginning. One of the persons who started that is sitting in the room here. Putting the patient at the center of what we do. So we do structured assessments of barriers with personalized plans, phone access to clinicians, STI services, and very importantly, psychological support and referrals to counseling for trauma or gender-based violence. And we do ongoing training, role-playing, case studies with our providers on patient-centered care. So this is like a very complicated graph, but I'm showing this to, what this graph shows is each horizontal line is what a patient is doing over a 12-month period in terms of whether they are taking a biomedical prevention intervention, PrEP or PEP, and then different colors are whether they report being at risk or not. So optimally, a person at risk, green, kind of green depending on your color view, is taking PrEP or PEP. What's bad is the red color, which is a person knows they're at risk, they're saying they're at risk, and they're not taking anything or using any prevention. So I think the point to make when you look at this graph is people are taking things, they are changing over time. Some people are not taking anything, and some people are going in and out of risk periods. And this is what we need to do. We can't do a one size fits all. It's like, oh, do you want to take PrEP? Well, here you go. You have to take it for a whole year. That may not work for many people. It works for some. And we know if you take it, it works fabulously. But people's lives are complicated. And having these options, what we were testing is, if we offer prevention in this way, could we have more covered time? And we presented these results at CROI this year and 3 oral abstract sessions, and hopefully they'll be coming out in publications sometime in the next couple of months, but it worked. Okay, so what we saw compared to the standard of care, that we saw an increase, and these are the 3 settings we did the study: in the antenatal clinic, in the outpatient clinic, and in the community with our via our community health workers. We saw an increase in biomedical prevention coverage. Well, that's great. I could show you all the statistics of this. We looked at it many different ways. Yes, it's true, it's robust. But honestly, look at the absolute intervention coverage. Completely unacceptable. Look at the community. It's only 28%. We know we need new products. We have new products, and which is very exciting. And in this study, I'm happy to report that we already started adding CAB-LA as a prevention choice in December of last year. So by December of this year, we're hoping to have data early next year that we can share with the world about what happens, when you have the standard options available, and then you add on CAB-LA. And sneak preview, I can tell you a couple of things, is that absolutely a lot of people want injections, but not everybody. Okay. And some people are very happy being on PrEP. Some people still want to do PEP and then, go back to something else. So I think how we do this is such a real world setting will hopefully inform the rollout of that. So, we talked about, I was saying, like, what's in the future. Certainly it's here now. We've got CAB-LA, long-acting agents, and then very exciting new drug on the block, first in its class, capsid inhibitor, lenacapavir. That's now available for treatment for patients and can be given every 6 months. So 2 trials, Purpose 1 and Purpose 2, would aim to look at lenacapavir versus nucleosides for prevention in 2 different settings or populations that really were similar to what was done in the CAB-LA studies, adolescents and young women in sub-Saharan Africa, and then the US, some sites in US and South America for men who have sex with men and transgender women. Okay, so the third thing I talked about was getting into the community. So I mentioned to you that we're doing Search 2.0, and I showed you results from our pilot studies. We really want to understand choice and CAB-LA and how we do it. So our hypothesis in the Search 2.0 study that we're testing is that community precision health will reduce HIV incidence and improve community health at a population level. And we're doing this in a community cluster randomized implementation study, and we work with our partners in rural Uganda and Kenya. Well, what is community precision health? Well, here's a short definition of it, which is an AI-enabled extension of HIV multi-disease prevention and care from clinic to community and back. And this is really one of my favorite photos of the year. You can see on your upper left, what we're doing is community health workers in rural areas where we work for decades. They go to every single house. They know who lives there. They have a census, and they essentially do malaria care and maternal child health. We've now expanded that to include HIV services, and we picked one NCD, which is hypertension, with the community health workers. So we're leveraging existing infrastructure, and we're adding another layer of informatics and technology. So our team developed an app. We're working with ministries of health using open source, and worked with our users, which were the community health workers, and we trained them on use. We did all these sessions, and you can see that picture is one of our staff, a young woman training one of the community health workers. We launched this study in March, and we're rolling it out. It is so exciting to see the enthusiasm for the community health workers. And what we're doing is, by doing this, we are connecting the community work and the brick and mortar health system. So we're really, our theory is that we'll be able to reach more people. Okay, now pivot to the United States. Okay, 1.2 million people living with HIV. New HIV infections still in the 30,000s. And you're going to hear the Diane Havlir commentary on my reaction to that number. It's not a headline, oh, our new HIV infections in the US are decreasing. Every time I see one of the headlines, it drives me crazy, and I will tell you why. And then deaths due to AIDS, 18,000. Okay, so where are we at just in terms of knowledge of HIV diagnosis in the United States? From the CDC, approximately 90%. The graphs below is for men who have sex with men, about 86%, heterosexual contact, 88%, and then people who use drugs, about 92%. So all hovering somewhere around 90%. So we want to diagnose people as early as possible. And we all know why, because the outcomes with late diagnosis, we really can't reverse all the things with HIV. And we want to give people treatment upon diagnosis. This has been a mantra. This has been the program that was started really in San Francisco and developed here. But nevertheless, we still have people around the United States and around the world with late diagnosis. And this is a heat map which shows the heterogeneity in the United States of late diagnosis. And what you can see is some of the states, which is the darkest, which are the highest. But honestly, we still have late diagnosis everywhere, including in San Francisco. And we just need to work harder to ensure that people are diagnosed and get linked to care. Okay, audience response 2. What's the percentage of persons living with HIV in the United States who have achieved viral suppression? So 55%, 60%, 65%, 70%, or 75%. Okay, let's see if we can get some more answers there. If I see, well, should we just try it and see what we've got? Oh, okay, great. Okay, so most people said D, 70%. Wish you were right. It's a little bit lower, approximately 65%. Just really very sobering. And also we've got some disparities, which are, what you can see is the top number is men who have sex with men, 69%, heterosexual contact, 64%. I don't think this will surprise anybody in this room. People who use drugs, it is much lower. This is just really shameful in the United States that this is the state of affairs, only 56%. We have young people with HIV in the United States. We also have an aging HIV population, which is a true success of antiretroviral therapy. And if we look at all over the United States, across the United States, about 50% of people living with HIV are over 50 years. And when I work with the fellows in clinic, what I say is every single day we're seeing the natural history of HIV as people get older. And this is a big focus here at our clinic in the Golden Compass, here at our, and really around the world to ensure we are taking the best care of people who are aging with HIV. I was so happy to see this in the CDC report this year, which was an estimation. I have no idea how accurate this is, but at least it's calling out this as an issue of the unmet need for a mental health professional services for people who are living with HIV. And so we have a large, unacceptable proportion of people who really require or need mental health services, and this need is not being met. I mean, this is an overall crisis in our country for really, I would say, every age demographic, but we really need to focus on this. Okay, so this is this number. So over 30,000 people are newly infected with HIV. Not only this number barely changed, but the huge disparities, this is like, I feel like I'm a broken record. Every single year, say the same thing. The demographic groups of the people who have the highest proportion of new infections are Black African Americans, Hispanic, Latinos. But honestly, new infections are completely preventable. So every single person on this, we have failed to really offer the preventative services that we could for these individuals. And what's our assessment of PrEP uptake? It's too low. This is the PrEP coverage in the United States heat map. Like this, you say, oh, well, look at all the dark purple. But you need to realize, in order to qualify to be dark purple, you only have to have 26% of the people who are estimated to be in need. That is a very, very low bar. So I'm not really sure we should be celebrating that. So once again, I know we have a lot of people who are working on this. We have new products, but this really does need to be a focus area. And it's estimated that of the 1.2 million people who could benefit from PrEP, only 30% have been prescribed. And once again, that's prescribed, let alone do people have the appropriate support services? Are they getting adherence support? Are we ensuring that they don't have to pay, unaffordable out-of-pocket costs? There's all sorts. When you open the hood on this is a really complex problem. So no, I didn't forget to put something over here. I'm going to add something to this. I want to just talk through this graph, which shows the trends of the new HIV infections in the United States. And this is my beef. It's like 2010, we were over 30,000. In 2021, we were over 30,000. I don't know how you could say that this is a huge success. Think of all the resources we have. Think of all the tools we have in the United States. And you've seen some of these other places around the world. I know I wasn't at IS this year, but Australia has really done a fantastic job. So that is where we are at in the United States. And talk about being off track. Look at where the X is. That is the target for the end the epidemic in the United States. So there was this graph is from an editorial that was written in Lancet HIV this year. And the question was, is the USA on track to end the HIV epidemic? The answer is no. Okay, it seems pretty obvious. And these authors, I would agree with these, say we need to reduce stigma, mitigate social determinants of health, broaden the health workforce, and reinvest in health. And really, the reinvest in health is just to make sure we're overcoming we have just such a complex, fragmented health system with all these complex co-payer referrals. You're changing your health system really to try to address those things. There was a lot of talk about the problem in these problems, which I think we would all agree of in this editorial. I would say it was a little bit thin to me on a solutions. I want to be an action-oriented person. I also think that there are other things that are really, really important. We need to talk about community. We need to empower community. We need to get in the community. We need to link community to our brick and mortar facilities. We need to keep investing in research, not only in new products, but also how to deliver those products. And we need to make sure we don't have HIV in a silo. We need to make sure that we have comprehensive, really patient-centered services. So that's just my editorial on this editorial about where we're at in the US. So we are definitely not on track in the United States. Our progress, depending on how you interpret, yes, I am happy that it's going down a little bit, but I would say it has stagnated. These huge disparities persist. They may increase. I think we're all very concerned about these new political moves that could increase discrimination and access, that tools prevention are not being utilized and implemented, and access is too cumbersome. HIV care for seniors needs attention, as does mental health and substance use disorders. Okay, negative, negative, negative. Let me do some bright spots, okay? Bright spot, what's happening in San Francisco? Innovative programs can change its trajectory, and I will show you evidence of this. And a bright spot is there are continued investments by the private sector for products, for diagnostics, and we really need to support that, and by the National Institutes of Health. Okay, so let's talk about San Francisco. This is from our annual report that was released in 2022. We have 15,000 people living with HIV. We have 160 new HIV diagnoses and 286 deaths. So this is also a heat map on your left, which shows in our city the different neighborhoods where the highest number of individuals are living with HIV, very much concentrated on what we call in San Francisco, the market corridor. In San Francisco, I told you 50% of the people in the United States are over 50. In San Francisco, that's 70%. Our viral suppression estimated, we do it differently here, somewhere around 72%. And that's shown in this particular graph on this slide. Okay, so new HIV infections. This looks a little bit different. Okay, you can see that geographically it's kind of shifted more towards the eastern neighborhoods in our city, and we still have disparities, absolutely, in new HIV infections, and over 50% of the diagnosis of new HIV diagnosis are in persons of color, and the highest proportion of new diagnoses are among Latinos in San Francisco. So this is a different way to look at these data, that the annual rates of HIV infection are highest in Black and Latino men. You can see the gradual decrease, but the rates are still too unacceptably high and show the disparity. And I'm looking at Liz, Dr. Embert, right now in the front row here of Dr. Embert really works in this space, as Dr. Hickey and many others sitting here. This is just really hard to wrap your head around. So 1 in 4, this is probably like an underestimate of new diagnoses are in people who are classified as homeless. And this does not even include individuals in San Francisco who live in single room occupancy settings, or SROs, who couch surf, or who are using other things like storage garages in order to live. So this really tells us something about our city, about us, I would say, as people, of how we're allowing this to happen. And I know a lot of people are working very, very hard on this. This is another graph which shows the continuum of care for people newly diagnosed with HIV, and our the really innovative RAPID program that was spearheaded here, run now by Dr. Sousa Coffey in our clinic. You can see that we have 81, at least across the city, where we spread this across the city, the RAPID program, 81% viral suppression at 6 months. So what about PrEP in San Francisco? In the annual report, they shared with us our city clinic, which is our public health sponsored clinic, where people go for STD care, for HIV care. And I think what these graphs show, that we've had a gradual increase in PrEP. This is really great. We're tracking our disparities. We got to bring up our access to PrEP for African Americans. And we can see the San Francisco AIDS Foundation at Strut and their multiple sites, I would say, is doing a phenomenal job with PrEP, both daily PrEP and offering 211 PrEP. So getting to zero, Dr. Gandhi mentioned this in the introduction, Susan Buckbinder and myself, Dana Van Gorder, Jeff Sheehy, the man living with HIV, and the foundation. We started this in 2013, and the idea is this is a freestanding, independent entity that works under principles of collective impact. All of us have our regular jobs, but we come together with a goal in mind, which is really to reduce new HIV infections in San Francisco and also improve the lives of people living with HIV. When we started, we had our 4 main pillars were get PrEP out citywide, get treatment on diagnosis with rapid ART starts, strengthen linkage and engagement to care. And then we had also efforts on stigma in adolescents and young health. So what we can see from this graph, which looks very different from the United States graph that I shared with you. You can see when we started getting to zero, pre-getting to zero, we had decline in HIV diagnosis, 28% in 7 years. Post getting to zero, a 53% decline in 5 years. And this contrasts to the United States, which is 9% in 5 years. And once again, this is not due to any single person. This is due to the community, the health department, the private sector, the academics, all coming together and saying, what's going to be our strategy for us to keep this improving? So, let me go back here. It's so hard to see. Sorry about that. 160 new HIV diagnosis. That was our last report. Our next report's not going to come out for a while, but we get a sneak preview in January that's published online for what the estimated new diagnosis is going to be in 2022. So, drum roll. What does everyone think this is going to be? Think of all these things we're doing in San Francisco. Think of that homeless slide I showed you. Think of the last time you went on Market Street. Okay. Thank you, Liz. Okay, most people got it right. It is 158, essentially no change. Now, we all know there are all sorts of nuances of HIV diagnosis with the emergency phase of COVID and all that, but I think we're pretty much steady, and that is what we've studied. But steady is not good. We want to have reductions. So that's where we're at. Wow, we do have some optimists, thank you, and some extreme pessimists. Okay, so that's the answer, 158. So we did a reboot of Getting to Zero in 2021, and we said, okay, the pandemic is evolving, we need to evolve. So we did extensive training on racial and economic justice. And these are where we're focusing our efforts. We have rapid ART start and restart. Thank you, Dr. Coffey. She's really spearheading these efforts, okay? Because some people just drop out of care. And then when they come back, we want to make sure that they get on therapy in a safe way. We have new options for PrEP and PEP. We have now a focus on people with unstable housing. I do not need to justify you why we're doing that. And then we're focusing on HIV and aging. Then we also have really focus areas, COVID, Mpox, overdose prevention, youth, doxy-PEP, and long-acting. And our website has a lot of resources. And thank you, Dr. Gandhi, who posts our long-acting protocol. I'll mention this when I do kind of the my quick takes on what clinicians can do this year about the protocol in Ward 86 of delivering CAB rilpivirine for people with viral suppressions and people who don't have viral suppression. So this is an incomplete list. I'm so proud of all the things on this list. Strut, I think I mentioned from the AIDS Foundation, you walk up, you say what STD test you want and you get it, and it's very low barrier. That's in the Castro, the pop-up program for people with unstable housing and non-viral suppression. I see Matt Hickey and Liz and all others working on this program. PrEP City Clinic, street medicine, overdose prevention. Kaiser has some great services and actually has really led the country in a lot of ways on PrEP. And we have new health access points in Building 80. We have a new health access point, which is very, very exciting. You will hear more about that in grand rounds this year. Okay, so let's go to rapid fire. Okay, so I've got 5 rapid fire. So now we're going to get to pragmatic things for us. And this is really a kind of a preview for what we're going to be. Liz and Aisha gave you a preview, but this is very, what are the important topics? Okay, how do we increase patient satisfaction with HIV therapy and viral suppression using the long-acting agents? improve cardiovascular health, reduce anal cancers, reduce STIs, and increase options for prevention. Okay, so patient satisfaction. The SOLAR study was presented at CROI this year, recently published in Lancet HIV. This was a randomized study that had people with viral suppression on Biktarvy, and they were switched either to long-acting or maintain on Biktarvy. So the headline result of this was that that the long-acting was non-inferior to viral suppression, and people who took the long-acting were more satisfied. They were happy. They had like this huge sense of relief. I want to mention a couple of caveats out of this study. Okay, this is good. Okay, but excluded people with Hep B. Remember, the long-acting regimen does not cover Hep B. Excluded people who use drugs. Excluded pregnant women. Okay, these are important populations. And also, when we look at people with over 50 copies at their primary endpoint, there were 5 people in the long-acting arm and only 1 person that was over 50. And of those 5 individuals in the long-acting arm, 3 had drug resistance. Okay, it's a low percentage, but I think this is just really important to note. Secondly, the Annals paper, this is from this really fantastic program led by Dr. Gandhi and really beautiful research by Dr. Christopoulos that just showed these early results, and they're increasing every day. 133 persons treated with CAB, rilpivirine, and 57 of these people started with unsuppressed viral load. These are people who just simply could not take oral therapy. If they didn't take it, they could die. Okay, I mean, their T cells were low, they were in dire situation. And what this showed is that there were high levels of viral suppression. We need to understand resistant. Longer follow-up is happening, but really, really hats off for this, and really happy to see this in the literature. There was an editorial that was written on the SOLAR study. I just wanted to have a tiny little quote from there that really stuck with me. And this was written by Tara Vijaran. She was one of our former ID fellows who's now at UCLA, and Judy Currier, who is a very prominent HIV clinician and researcher. And they were talking about the SOLAR study, and they were talking about long acting. And this is what they said, is that the benefits are going to languish at hands of systems ill prepared for innovation. It just doesn't happen suddenly that you can have a long acting program. You have to do a lot of things. Okay. And that's what's being done here at Ward 86. That's being done at some clinics, but I think that is very, very important. Okay. Number 2, as clinicians, we need to improve the cardiovascular health. We need to use statins. The biggest study of the year was the REPRIEVE, presented at IIS, 7,000 patient study. Theory being that if we reduce inflammation with a statin, we're going to improve cardiovascular health for our HIV-infected patients who already have increased inflammation. Okay, they took individuals with low to moderate risk of cardiovascular disease. If you're a person like me who calculates a risk score is around 4, and what the study was stopped early because there was a 35% reduction in major adverse cardiovascular events. I'm not going to say anything more about this because next week at Grand Rounds, please be there. We are only going to talk about this. We're going to hear, what do the experts say about this study? What do they suggest you do in your clinic? How should we approach this? So, but this is really, I wanted to highlight this for this year. Third, last year we talked about this. For years, high-grade intraepithelial lesions we know in women for cervical cancer, you treat them, you reduce cervical cancer, right? So we never knew, what should we do with anal cancer? Now we know. If you have those lesions, you should treat them because you can prevent anal cancer. And hopefully we will also be talking about operationally how we can do this and how we can do better with this. Okay. Number 4, reducing STIs. We also in San Francisco have one of the highest, I think we're second only to Las Vegas with syphilis in the United States. So we have a lot of STIs in San Francisco. Okay. And now we have something that we can do about it. So the flagship study that was a randomized study led by Annie Lukemeyer here, along with Stephanie Cohen, Hyman Scott, Susan Buckbinder, demonstrated that a single post-exposure dose of doxycycline can reduce STIs by somewhere around 60%. I've got the data here. You can see this study included both people at risk for HIV who were on PrEP and people living with HIV. I'm so proud of our health department and Stephanie Cohen in particular, who have made a recommendation in San Francisco. I think we're one of the few cities around the United States that is suggesting that how shocking, put evidence into action, use doxycycline for STI prevention. Now, there's a lot of concern about resistance. We did not see, Dr. Lukemeyer reported this on CROI this year, we did not see excessive resistance so far. We're going to be responsible. We are going to monitor it. But this is a great intervention that we should be using. And in Getting to Zero, we're going to be looking at, are we offering this around our city, and are there any disparities? My final and fifth one is to increase options for biomedical prevention. We talked about CAB-LA. I'll just make one point about this. I love this abstract. This was at IAS. And what they did in the Whitman Walker Clinic, this was giving CAB-LA. They designed this program that was a combination of essentially clinicians and trained community health workers, okay? They don't have any professional training, to set up systems, making sure we're giving excellent medical care, but also that we're taking advantage of ways we can be more efficient in medical care, and also settings. So this was the picture where they have this beautiful picture of, it looks like Hawaii to me, and apparently there's music in the background. And the idea is that it eases anxiety. Who likes injections? And nobody likes injections. So while people get the injections, I love this. And they really studied it, and they said how they did it. These are the types of things that we need to really change that. Every single year, over 30,000 new infections in the United States. So I didn't have time to talk about these things: shorter TB prevention regimens, new approaches for persons using drugs. I know we'll hear about those, weight loss strategies, and many more. So my conclusions: HIV is a chronic and treatable disease. We're in the NST era, at the dawn of a very exciting long-acting era. Got tools to reduce new infections. The pace and magnitude will depend on implementation, a holistic approach. We, everybody sitting in this room and online, have a call to action to deploy new evidence-based interventions. And we need, despite talking all this, haven't mentioned cure vaccine, we absolutely need to continue investments in them, because we will need those to end the pandemic. And I don't have time to name all the wonderful, wonderful people that I have the privilege to work with, many of whom pictures are shown in this slide. So thank you.
Thank you so much, Dr. Havlir. That was phenomenal. If you want to come up to the lectern, you can ask Dr. Havlir some questions. Thank you, everyone.